بسم الله الحمد لله والصلاة والسلام على رسول الله صلى الله عليه وسلم. Inshallah, today in this lecture we will talk about the common toxic syndromes. Common toxic syndromes in clinical practice usually occur due to the following administration of the following drugs or group of drugs. First, acetaminophen, paracetamol, brand name known as Panadol. Then amphetamine and other CNS stimulant. This drug commonly abused by individuals due to their central effects, which they can call they can produce euphoria and other CNS stimulant effects. So also in clinical practice, their toxicity is very common. Then also the anticholinergic drugs that especially antimuscarinic agents, atropine and atropine-like drugs. Then antidepressant drugs, especially tricyclic antidepressant drugs that used for treatment of depression. Tricyclic antidepressants, selective serotonin uptake inhibitors, monoamine oxidase inhibitors. Generally, tricyclic antidepressant toxicity is the most common in clinical practice. Also, the antipsychotic drugs, especially phenothiazines and butyrophenones and other atypical antidepressants. Then salicylate, aspirin, salicylic acid. Also, the beta blocker toxicity, very common due to its wide use. Also, the calcium channel blockers of different types, dihydropyridines, الاملوديبين, النيفيديبين, الدلتيازيم اللي هو الفيراباميل, the other calcium channel blockers, also common. Then the cholinesterase inhibitors, especially that used as insecticide and pesticides such as المالاسيون and الباراسيون. Also, as we mentioned previously, they are used as chemical weapons such as sarin and soman and carbon. Its toxicity also is very common. Digoxin, which is the cardiac stimulant drug that have a positive inotropic effect that used for treatment of heart failure. Digoxin, due to its narrow therapeutic index, lower therapeutic index, its toxicity is very common. Also, ethanol and other sedative hypnotic drugs. Then ethylene glycol and methanol, also they are alcohol-like drugs. And last, theophylline, which is characterized as a digoxin, characterized with a narrow therapeutic index, that the difference between the therapeutic dose and the toxic dose is marginal or very low. Also, its toxicity is common in practice. First, we will talk about acetaminophen, paracetamol, aspirin. Acetaminophen is one of the drugs that mostly involved in suicide attempts and accidental poisoning. Suicide attempt اللي هي المحاولات تحت الانتحار ingestion of large doses of paracetamol or by accident. This is due to its availability because paracetamol is one of the over-the-counter medications that available in any supermarket, in any home. Due to its availability, so it may be involved in suicidal attempts beside an accidental, and accidental that is especially occur in children. Both are the sole agent لوحده or in combination with other drug. Acute ingestion of more than 150 to 200 milligram per kg in children, or more than 7 gram total in adults. 7 gram, this is mean about 14 tablets, because it's available as tablet 500 milligram. Is considered to be potentially toxic. A highly toxic metabolite is produced in the liver in case of ingestion of overdose or large doses of acetaminophen or paracetamol. And we'll talk in detail about this because the toxicity of acetaminophen result due to the its metabolism when it's occur in high doses. Under normal circumstances, acetaminophen is conjugated in the liver to form inactive glucurionated or sulfated metabolites. This is in the normal doses. While in case of high dose, all of the saturation conjugated site will be saturated, so the a portion of the acetaminophen will be hydroxylized by mixed fraction oxidase to form a toxic metabolite. This toxic metabolite is named as N-acetyl parabenzoquinone or benzoquinone imine, abbreviated by NABQI. N-acetyl parabenzoquinone imine, which is highly reactive metabolite that can react with sulfhydryl groups on the on the liver cells, hepatocytes, and this can lead to the damage of hepatocyte, leading to the liver damage. So in few words, we can mention that in case of large doses, acetaminophen, all of the saturation conjugated site, all of the conjugated site for paracetamol will be saturated, so a portion will be shifted to be metabolized by mixed fraction oxidase, which is a cytochrome B450 enzyme, that lead to production of a toxic metabolite that can affect directly the liver cell, leading to the liver damage. While at normal doses of acetaminophen, N-benzoquinone para-aminobenzoquinone imine reacts with the sulfhydryl group of glutathione, which is produced by the liver, forming non-toxic substances. Even if in normal doses there is a amount of paracetamol metabolized by this mixed fraction oxidase, leading to a toxic metabolite, this toxic metabolite can be neutralized by the natural antioxidant اللي هو الجلوتاثيون that available in the liver cells, and this will leading to formation of non-toxic substances. But in case of overdose, a large portion will be metabolized to this toxic metabolite, and all of the natural glutathione will be depleted, بينتهي, so that the remaining NABQI toxic metabolite will react with the cells, the protein cells, sulfhydryl groups of the proteins within the cells, liver cells, leading to the hepatotoxicity. With large doses, as I mentioned, of acetaminophen, the available glutathione in the liver becomes depleted, and the N-acetyl benzoiminoquinone reacts with the sulfhydryl groups of the hepatic proteins, forming covalent bonds, and this leading to hepatic necrosis. A very serious and potentially life-threatening condition can result from this toxicity. Patient with hepatic disease or viral hepatitis or history of alcoholism are at a higher risk of acetaminophen-induced hepatotoxicity. Those with liver disease or viral hepatitis or of a history of alcoholism, because alcohol had a bad effect on the liver, leading to maybe liver cirrhosis or fatty liver. They have high potential for acetaminophen or paracetamol induced hepatotoxicity. The adverse effects that result from acetaminophen toxicity, including dizziness, excitement, and disorientation, and these are CNS adverse effects. Ingestion of 15 grams of acetaminophen may be fatal, and this can be caused due to severe hepatotoxicity, as we mentioned, due to the depletion of glutathione, natural glutathione. This sometimes this hepatotoxicity is sometimes associated with acute renal tubular necrosis, result from the same mechanism. We have a specific antidote for the poisoning of acetaminophen, which is an N-acetylcysteine. The N-acetylcysteine is the specific antidote for the acetaminophen overdose or acetaminophen toxicity. It acts by providing sulfhydryl groups that act to neutralizing the toxic metabolites that result from the metabolism of large doses of acetaminophen, which lead to the toxic metabolite, which can be neutralized by N-acetylcysteine through N-acetylcysteine provide with the sulfhydryl group that react with the toxic metabolite, so neutralizing these toxic metabolites. Medication or herbals that induce the cytochrome B452E1 will increase the risk of hepatotoxicity, because this will lead to increased metabolism of acetaminophen to the toxic metabolite. These include phenobarbital, اللي هو barbiturates, and carbamazepine, and phenytoin. All of these are acting as anti-epileptic agents. Rifampicin, also enzyme inducer, and the ethanol and the St. John's wort plant. All of these can induce this enzyme or isotype of cytochrome B450, so this can lead to increased toxicity of paracetamol in case of overdose. The other drugs that may compete with the glucuronidation, leading to increase in the cytochrome B42E1 metabolism, including opioid, zidovudine, antiviral, trimethoprim sulfamethoxazole, leading to increase also hepatic toxicity. The treatment, as we mentioned, the antidote, the N-acetylcysteine acts as a glutathione substitute binding to the toxic metabolite as it is being produced. It is most effective when given early and should be started within 8 to 10 hours if possible. This is from the ingestion of the large doses or toxic doses of acetaminophen. Many institution-specific protocols exist for the administration of both oral and IV routes for N-acetylcysteine. These have been shown to be equally effective, orally and IV route, for this specific antidote for paracetamol acetaminophen overdose. The IV administration is recommended for the patient with in cases of hepatic damage. More often now, in most institutions that prepare the IV administration of the N-acetylcysteine as antidote for acetaminophen toxicity. And while the oral administration of this antidote, due to the sulfur, and the sulfur that characterized by the rotten egg smell, this is a bad smell, and the taste also, patients have trouble in tolerating the oral version of this antidote. The IV adverse effects include possible anaphylactoid reactions, severe rash, or hypotension. The activated charcoal is effective at absorbing the ingested acetaminophen that has not yet been absorbed. So it's if used as soon as possible, it will have a greater effect in preventing the absorption of the acetaminophen. Now we have salicylate and aspirin, also due to its availability. It's one of the drugs that can commonly cause clinical toxicity due to the overdose, either by accident or by intended suicidal poisoning. It still accounts for numerous suicidal and accidental poisoning because of its availability. Acute ingestion of more than 200 mg per kg is likely to produce intoxication. Poisoning can also result from chronic over-medication. This occurs most commonly in elderly patients that using salicylate for chronic pain such as rheumatic arthritis, who become confused about their dosing, so they can repeat the dose during the day, and this can lead to accumulative toxicity. Poisoning causes uncoupling of oxidative phosphorylation and disruption of normal cellular metabolism, leading to toxicity to these cells. The first sign of salicylate toxicity is often hyperventilation. This is a characteristic with the overdose of salicylate. Hyperventilation and respiratory alkalosis due to medullary stimulation. Metabolic acidosis follows this respiratory alkalosis followed by metabolic acidosis, and an increase in anion gap results from accumulation of lactate as well as excretion of bicarbonate by the kidney to compensate for the respiratory alkalosis. Arterial blood gas testing often reveals this mixed respiratory alkalosis with metabolic acidosis. So this we can, by the test, we can confirm it if there is an respiratory alkalosis or metabolic acidosis. Body temperature may be elevated due to the uncoupling of oxidative phosphorylation, and severe hyperthermia may occur in serious cases of aspirin toxicity. Vomiting and hyperapnea as well as hyperthermia contribute to the fluid loss and dehydration. With very severe poisoning, profound metabolic acidosis, seizures, coma, pulmonary edema, and cardiovascular collapse may occur. Absorption of the salicylate and the signs of toxicity may be delayed after very large overdoses or ingestion of enteric coated tablet. Enteric coated tablet that coated with the polymer that does not affected by the stomach. So when it's released to the small intestine, then it will be degraded and absorption can occur. Treatment of the aspirin overdose. General supportive care is essential. We haven't a specific antidote for salicylate poisoning, so the general supportive care is essential, as we mentioned in management of general measurement of toxicity. After massive aspirin ingestion, more than 100 tablets, aggressive gut decontamination is advisable, including gastric lavage or repeated doses of activated charcoal, and consideration of whole bowel irrigation. All of these to avoid or to prevent further absorption of aspirin from the GIT. Intravenous fluids are used to replace fluid losses caused by tachypnea, an increased rate of respiration, and vomiting on fever. For moderate intoxications, تسمم moderate intoxication with salicylate, intravenous sodium bicarbonate is given to alkalinize the urine and promote salicylate excretion by trapping the salicylate in its ionized polar form. And this is, as we mentioned, this is a excretion magnification in order to enhance the excretion of aspirin salicylate, because it is a weakly acidic drug. So by alkalization of the urine, this will lead to increased of ionization of salicylate لما يحصل له glomerular filtration, so the passive reabsorption will be reduced and increased amount of aspirin will be excreted in the urine. For severe poisoning, patient with severe acidosis, coma, and serum salicylate level that more than 100 milligram per deciliter, emergency hemodialysis is performed to remove the salicylate more quickly and to restore the acid-base balance and fluid status. Now we have the anticholinergic agents, which are also its toxicity is very common in practice, and we have a wide range of drugs that having anticholinergic activity. This is include the anticholinergic antimuscarinic drugs such as hyoscine and atropine, and the antihistaminic drugs which having anticholinergic drugs, phenothiazines, the antipsychotic also having anticholinergic effects, and many other drugs that having anticholinergic activity. Many prescription and non-prescription drugs, as well as a variety of plants and mushrooms, can inhibit the effects of acetylcholine on its receptor, especially the muscarinic receptors. Many drugs used for other purposes, as I mentioned, such as an antihistamine, also have anticholinergic effects. And also we mentioned the antipsychotic drugs, phenothiazine and butyrophenones also having a powerful anticholinergic effects. The anticholinergic adverse effects include, as you know, dry mouth, blurred vision, mydriasis, urinary retention, constipation, tachycardia, dizziness, confusion, nausea, and flushing. The patients usually have sinus tachycardia. This is due to the inhibition of the vagal stimulation. The vagal stimulation on the M2 receptor on the atrium. This will result in sinus tachycardia, and pupils also usually dilated. This is due to the blockage of the muscarinic receptor on the iris pupillae muscle. Agitated delirium or coma may be present, and this is due to the central effects of these anticholinergic drugs. Muscle twitching is also common due to these anticholinergic drugs, and seizures are unusual unless the patient has ingested antihistamine or tricyclic antidepressant, which both of them having antimuscarinic anticholinergic effects. In case of this, also seizures may be occur due to the effects of these antihistamine and tricyclic antidepressant on the central nervous system. Urinary retention is common, especially in older men, due to the prostate hypertrophy, benign prostate hypertrophy. The treatment of anticholinergic poisoning, the overdose of anticholinergic drugs, include first, largely supportive, as we mentioned, the ABCDs of the management of toxicity. Then agitated patient may require sedation with benzodiazepine and antipsychotic agents such as haloperidol. The specific antidote for peripheral and central anticholinergic syndrome is the physostigmine. We have for anticholinergic drugs, we have antidote which is a physostigmine. And why physostigmine, not pyridostigmine or other anticholinesterase drugs? Because physostigmine is a tertiary ammonium compound, so it is more lipid soluble, so it can cross the blood-brain barrier, and so it can antagonize the central effects of these anticholinergic drugs. While pyridostigmine and the other drugs cannot, which are quaternary ammonium compound, less lipid soluble, so they cannot cross the blood-brain barrier, so they cannot overcome the central effects of these anticholinergic agents. Physostigmine, which has a prompt and dramatic effect and is especially useful in patients who are very agitated. Very agitated, this is the sign of central toxicity. So this can be quickly overcome by the physostigmine, which is the cholinesterase reactivate inhibitor. So it leads to increased endogenous acetylcholine concentration, which tend to competitively antagonize the effect of these antimuscarinic or anticholinergic agents. Physostigmine is given in a small intravenous doses, 0.5 to 1 milligram, with careful monitoring because it can cause bradycardia and seizures if given too rapidly. Physostigmine should not be given to a patient with suspected tricyclic antidepressant overdose because it can aggravate the cardiotoxicity, resulting in heart block and asystole. Catheterization may be needed to prevent excessive distension of the bladder due to الانتيكولينرجيك effect في السموث muscle of the bladder. Now we have the cholinesterase inhibitors, which are also called anticholinesterase drugs, which have the opposite pharmacological effect to the previous one, anticholinergic drugs. They have the opposite effects of the anticholinergic drugs. Actually, the cholinesterase inhibitors in the practice, they are responsible for toxicity due to its wide use for non-medical purposes, such as insecticide, as I mentioned, the chemical weapons. The organophosphate and carbamate cholinesterase inhibitors are widely used to kill insects and other pests, so they are used as insecticide and pesticide, fungi, and weeds. Most cases of serious organophosphate or carbamate poisoning result from intentional ingestion. That is يعني حاجة إرادية, intentional ingestion by the suicidal person. But poisoning also can occur at work, pesticide application and or packaging, or rarely as a result of food contamination. Also intentional and also by accident, can be arise from an accident poisoning, which commonly occur among the farmer who use these insecticides. Actually in Sudan we have a case like this among the farmers. المزارعين هم بالصدفة كانوا خاتين البستيسايد ده في بوتل one of the drink bottles، وهم عاوزين يدعشوا متخيلين انه هو عن زيت يعني، انستيت استخدموه، فهو كان سبب للتوكسيسيتي بتاعتهم والديس بتاعهم نتيجه للبويزنينج with these cholinesterase inhibitors. So it is in practice it's very common either in suicidal attempt or by accidental poisoning. This which commonly occur as insecticide, we have malathion and parathioin also, and this carbamyl insecticide and pesticide. All of these is pharmacological effect through inhibition of cholinesterase enzyme, and this, as we mentioned in the pharmacology previously, this effect act to inhibit or resulting in depolarizing blockage, especially في neuromuscular junction, the motor end plate, and this will affect voluntary muscle activity. Also will eventually will affect a diaphragm, and this will lead to respiratory failure, and the cause of the death due to toxicity of these drugs usually result from mainly from a respiratory failure due to the relaxation that occur among the diaphragm muscle. Stimulation of muscarinic receptors causes result in abdominal cramps, diarrhea, excessive salivation, sweating, urinary frequency, and increased bronchial secretion, and this is directly due to the muscarinic receptor stimulation. Stimulation of nicotinic receptor causes generalized ganglionic activation, which lead to hypertension and increased tachycardia, or sometimes accompanied by reflex bradycardia. Muscle twitching and fasciculation may progress to weakness and respiratory muscle paralysis, and this is the last event which lead to the death due to respiratory failure. In this table, we have the signs and symptoms of cholinergic poisoning due to the anticholinesterase drugs, which result in excessive endogenous acetylcholine. The muscarinic effects include miosis, blurred vision, lacrimation, salivation, sweating, wheezing, bronchorrhea, excessive bronchial secretion, abdominal cramping, nausea, vomiting, and diarrhea, bradycardia, and other cardiovascular effects, urinary and fecal incontinence due to the stimulation of the smooth muscle of both urinary and GIT smooth muscles. While the nicotinic effects include pleural muscle fasciculation, cramps, weakness, respiratory insufficiency or arrest, paralysis, tachycardia, hypertension. The central effects include headache and anxiety, restlessness, confusion, psychosis, ataxia, seizures, and coma. As we mentioned, these central effects include agitation, confusion, and seizures. The mnemonic dumbbells. This will help to memorize these adverse effects. Dumbbells, each letter. Dumbbell from the D from the area, U from urination, M from meiosis and muscle weakness, B from bronchospasm, and E from excitation, and L from lacrimation, and S from seizures, sweating, and salivation. This can help to recall this common finding adverse effects that result from the anticholinesterase drugs. The treatment, we have general supportive care should be provided. Also, extra precautions should be taken to ensure that reusers and healthcare providers are not poisoned by exposure to contaminated clothing or skin while they using or dealing with these poisoned individuals. This is especially critical for the most potent substances such as parathion or nerve gases agent, because they are very potent, so they can be absorbed quickly among these circuitous or mucosin, and this can result in toxicity of these health care providers. The antidotal treatment consists of atropine and pralidoxime, as we mentioned previously. Atropine to antagonize the muscarinic effects that are responsible for a wide range of side effects that result from these drugs, while pralidoxime is a non-ad choline esterase reactivator, which tend to reactivate the enzyme from these inhibitors. Atropine is an effective competitive inhibitor at muscarinic site, but has no effect on nicotinic site, as we know, while pralidoxime, which should be given early enough, can restore the anticholinesterase activity by reactivating the enzyme from the organophosphate compounds, at both muscarinic and nicotinic sites. Now we have the beta blocker, and the beta blocker, due to its wide use for treatment of cardiovascular problems such as hypertension or ischemic heart disease and other non-cardiovascular symptoms such as migraine and cytotoxicosis. Its toxicity in practice is very common in case of large dose. In overdose, these drugs block both beta 1 and beta 2 adrenergic receptor that is selectively, if any, is lost at high dosage. Although many of these beta blockers, such as atenolol, which is selective beta 1, but in case of overdose, there is no selectivity, because selectivity will be diminished with large doses. Atenolol with large doses, although it's a beta 1 blocker, it can also block the beta 2 receptor. The most toxic beta blocker is propranolol. This is due to its effect on sodium channel receptors. It can block the sodium channels, such as like quinidine. So it can have other additional cardiovascular effect, and this is beside that propranolol is also lipid soluble, so it can cross to the CNS and can having the central effects. This is maybe because propranolol has additional properties. At high doses, it may cause sodium channel blocking effects like those seen with quinidine-like drugs and class 1 antiarrhythmic drugs, and it is lipophilic that allowing the propranolol to enter to the CNS and producing CNS effects. Bradycardia and hypotension are the most common manifestation of toxicity that observed with the beta blockers. Agents with partial agonistic activity, intrinsic sympathomimetic activity, as we mentioned that some of beta blockers having an intrinsic sympathomimetic activity, such as acebutolol and albendazole, can cause tachycardia and hypertension less than bradycardia and hypotension due to its partial agonistic effect compared with other beta blocker in overdose scenarios, example acebutolol, bendolol, and oxbrinolol. Seizures and cardiac conduction block resulting in wide QRS complex may be seen with propranolol overdose. The treatment of beta blocker, we have general supportive care should be provided as in case of other intoxications. And we have a specific antidote for a beta blocker we will talk about. First, we should atropine, IV atropine 0.5 to 1 milligram. This is in order to increase the heart rate. Also, IV fluids bolus 1 liter 0.9% sodium chloride. This is to increase the circulating volumes of fluids. Also, other treatments options order of use varies by severity of the overdose according to the patient situation. IV glucagon, this is also considered as antidote for beta blocker poisoning or beta blocker intoxication or beta blocker overdose, which given as bolus or infusion. Glucagon and the rationale, the pharmacological rationale for giving glucagon, because the beta blocker, all of the beta blocker tend to act by decreasing the second messenger, the cyclic AMP, and this can result in case of the heart will decrease the heart rate and the force of contraction, while glucagon tend to increase the second messenger, the cyclic AMP, and so that it can antagonize or can terminate these effects of beta blockers. IV calcium also can be given to treat in treatment of the beta blocker intoxication. IV vasopressive such as the epinephrine and norepinephrine also can be used according to the patient situation. This in case of there is severe hypotension, because they can increase the peripheral vascular resistance due to the vasoconstriction, and this can lead to increase in the blood pressure. High dose of IV insulin and glucose also can be used in the patients that are suffering from severe cases of beta blocker overdoses. IV lipid emulsion treatments also available, and we have, according to the protocols that by different institutions, the use of these all of these drugs can be used according to the situation of the patient situation, that according to the toxicity or the degree of toxicity that produced by the beta blockers. Glucagon is a useful, as I mentioned, glucagon is a useful antidote that, like beta agonists, act on the cardiac cells to raise intracellular cyclic AMP, but does not through stimulation of glucagon receptor rather than beta adrenoceptor. It can improve the heart rate and blood pressure when given in high doses, such as 5 to 20 milligram intravenously. Adverse effects of glucagon can result in nausea and vomiting, common. Prophylactical antiemetic so should be recommended to prevent the nausea and vomiting that can result from glucagon. We have 5-HT3 receptor antagonist is preferred, such as ondansetron. 5-HT3 receptor antagonist as an antiemetic, prophylactic antiemetic, to avoid the nausea and vomiting that can result from glucagon administration. Lastly, we will talk about the calcium channel blocker. Calcium antagonists can cause serious toxicity or death with relative small doses that compared with other drugs. These channel blockers depress the sinus node automaticity and slow the IV node conduction. So its main effect on the heart will be pronounced on both of the atrium and ventricle, SA node and AV node conduction will be affected by the calcium channel blocker. They also reduce the cardiac output and the blood pressure. Serious hypotension is mainly seen with nifedipine اللي هو vasoselective calcium channel blocker are related dihydropyridine, but in severe overdose all the listed cardiovascular effects can occur with any of the calcium channel blocker, is it dihydropyridine or diltiazem or even alverapamil. The treatment required general supportive care. Since most ingested calcium antagonists are in a sustained release form, it may be possible to expel them before they are completely absorbed لأنه we have a sustained release drug دائما هي بتقعد فترة أطول في الجي اي تي، فبالتالي ممكن نعمل لها اكسبيل either by through an activated charcoal or even by through a gastric lavage. We can expel them, and so we can prevent or decrease the absorption of these sustained release tablet. Initiate whole bowel irrigation and oral activated charcoal as soon as possible before calcium antagonist induces ileus interventions, because it can also lead to decrease the movement of the ileus. So it is if we use it as soon as possible, it will be better to prevent the absorption. The treatment of calcium channel blocker toxicity, the first line treatment, according to the guidelines, don't prioritize one over another. ما في واحد مفضل عن الآخر. All of these treatments may be used simultaneously. These treatments include IV calcium in order to increase the blood pressure and the contractility of the heart, IV norepinephrine to increase the heart blood pressure and to epinephrine to increase the heart rate and the contractility. The high dose of insulin glucose also to increase the contractility and the blood pressure. IV dobutamine or dobutamine selective beta 1 agonist or epinephrine to increase the contractility, especially if the patient in a case of cardiogenic shock. The IV atropine to suppress the vagal stimulation in a dose of 0.5 milligram every 3 to 5 minutes for treatment of bradycardia. If there is a myocardial dysfunction that present in the patient and the patient refractory to the above treatment, recommend incremental doses of high dose insulin and IV lipid emulsion treatment for treatment of this refractory patient that not respond to the above medication. I think that is all regarding this the first lecture in common toxic syndrome. Thank you, and assalamu alaikum wa rahmatullahi wa barakatuh.